Hello, thank you very much. I'm really happy to be speaking today about the pediatric home mechanical ventilation. I'm currently based in Italy, but I'm still working along the pediatric team at the Royal Brompton Hospital and with the Dubovitz Neuromuscular Centre in London, keeping my connection going with UK. I have no conflict of interest related to this presentation. So today we're going to go through the definition of home mechanical ventilation, what are the main and mostly used mode and types of patients requiring home mechanical ventilation. And I will try to share some experience of home mechanical ventilation on children with neuromuscular disorder and look at how things have changed in order to feedback on changes on new therapies especially on spinal muscular atrophy. And I will go through some experience on children with Trisomy 21 and congenital central hypoventilation syndrome. And I will also go through how things have changed in terms of remotely manage and monitor these patients. So when I prepared this presentation, my agenda was what is new in home mechanical ventilation. In other terms, what I should be highlighting to you. And I think we have new patients because we have new disease phenotypes, all disease but new phenotypes with the availability of new treatments, new approaches because we now are using ventilation also as a rehabilitation tool in addition to vital support as it used to be, particularly again on SMA type 1 and new technologies. So we have remote management, but also remote follow-up and diagnosis and so forth. So the main goal of home mechanical ventilation in children are short-term. So it includes relieving children from symptoms, reducing the work of breathing, but also and ultimately improving the gas exchange, but also allowing children to reduce intubation and minimizing risk of acute events. But also long-term, because we would improve the quality and the duration of sleep, maximizing the quality of life and prolonging their survival. And ultimately, what we are trying to achieve is to allow children to reach their developmental potential, whatever it is, based on their underlying condition and their health condition. So for home mechanical ventilation, we'll go through mainly or almost entirely speaking about and referring to non-invasive ventilation. But we have also invasive ventilation that can be carried out and maintained as a home support and is used when there's failure to adequately ventilate with children with non-invasive ventilation, but also when children are unable to tolerate mask, or also when there is such a severe degree of bulbar dysfunction that there is a risk of ongoing aspiration, and when the management of secretion is no longer possible with a non-invasive ventilation mask. Usually is when patients are so severe that depend for or are supposed to are forecast to be dependent on assisted ventilation for more than 16 hours per day for long time. So the first choice is the non-invasive support. And in children versus adults, so when we consider non-invasive ventilation compared to adults, we need to consider that children need more sensitive trigger. They need lower tidal volume and low flow rates. But also they are growing children, they're growing beings. So we need to be very flexible in terms of choosing the adequate mask, but also be flexible to change them along the way. And we also need to be mindful that are very high risk to develop mid-facial hypoplasia. So we also need to consider swapping mask very often to reduce this risk. Usually, children are ventilated on pressure support ventilation, which can be delivered either spontaneous, but more often as spontaneous type mode. And this is the type of ventilation where we set a supported spontaneous breathing, allowing children to trigger themselves and not lose whenever it is possible, according to their underlying condition, able to trigger breath, but support their breath. And also combining those with mechanically generated acts during sleep or for the more weak children. But some children are so weak or are have such a reduced threshold and reduced respiratory drive centrally that needs the pressure control ventilation, where we set the duration of the respiratory act, the respiratory rate, and the respiratory-expiratory ratio. So we are assuming they have absent respiratory effort or a very, very low trigger ability. And we can also use as a additional support to any of these modes, the average volume assured pressure. So this means that we can set a tidal volume that is desired according to children condition and weight in order to adjust this the pressure accordingly. And this is particularly helpful in children where we know that REM or non-REM sleep disorder breathing are more likely to happen. In terms of number, the need and the support of home mechanical ventilation, thanks to the more advanced home mechanical ventilation device, but also to the increased survival thanks to the overall multidisciplinary care, the use of home mechanical ventilation has grown exponentially. In the bar chart, you see the experience of one center in Italy, and you can see in the last 12 years how children have exponentially grown in terms of requiring home mechanical ventilation. But this really is an experience that is shared across Europe, across internationally, but also similar trends are found in middle and low income countries. In terms of population benefiting or being established on home mechanical ventilation, you can see in blue and in light blue the percentage of children requiring mechanical ventilation are either muscular dystrophy or spinal muscular atrophy. So in other words, around 60-70% of the children in this one center experience had neuromuscular condition. Another very high percentage of patients, 30%, had obesity, and cystic fibrosis, just a minority. So in terms of the population being established on ventilation, in terms of their pathophysiology, so the first is hypoventilation. So those children who have such a degree of muscle weakness or who develop along the way such a degree of muscle weakness that are unable to optimally develop or maintain gas exchange, particularly overnight. The second group of patients benefiting of home mechanical ventilation are those patients who have obstructive sleep disorder breathing, either because of abnormal craniofacial feature or abnormal tone of upper airway. And part of those are also related to obesity, but this is much more a specific case with a specific definition of hypoventilation related to obesity. And then the third group is characterized by those patients who have much more central sleep disorder breathing, and the typical example is congenital central hypoventilation syndrome, but also Prader-Willi syndrome. And I'm not going to go through details in terms of those genetic syndrome characterized by periodic breathing or breath holding, but these are also part of those benefiting from mechanical ventilation. And we're lucky enough that last year, end of last year, the ERS group of experts have issued a ERS statement on pediatric long-term non-invasive support. And in terms of the indication to home mechanical ventilation, there are, let's say, objectively determined thresholds, such as desaturation or minimum saturation below 90%, or a number of desaturation or a period of desaturation below 90% for longer than 22% of recording time, either hypoventilation, defined as more than 2% of recording time spent with AP TCCO2, transcutaneous CO2 of 50 millimeters of mercury, or elevated ODI or elevated AHI, cardiorespiratory polygraphy. But clearly, these are not the only one criteria to chosen to initiate NIV. Very important to consider the overall status of the children, the underlying condition, the prognosis of the condition, and, for example, the history of recurrent chest infection. In terms of setting, the ERS guidelines suggest to start the pressure of 8 centimeters of water and up titrate up to 10-14 in terms of IPAP, whereas for EPAP, we should be starting at 4 centimeters of water and then increase not higher than 6. However, clearly, depending on the children, condition, age, and so forth, higher pressure have been also used. And in terms of tidal volume, we should be, target or achieving is between 6 and 10 milliliters per kilo. And usually what has been considered a target for respiratory rate in children who are supposed to have a low trigger is 2 to 3 breaths below patient respiratory rate. Again, I want to underline that this is not respiratory rate per age, but each patient should be assessed preferably during sleep, if not possible during wakefulness, to target the respiratory rate 2-3 breaths below patient's respiratory rate, not the supposed respiratory rate according to age. And this is because in some children, respiratory rate is much, much higher than what is supposed to be for their age. Then there is the choice of the device, because we need to consider not all, one size doesn't fit all, and we know. And this is an example of a flowchart used at the Brompton for CPAP, depending on patient's dependency, so below or above 17 hours a day, and according to their weight. So in other terms, and this is similar to NIV, so in other terms, we should be able to choose the device according to the condition of the children, to the ability of children to require support, so the clinical condition of that particular time, but also in the long or medium term at least. And we should be providing 2 ventilators if children are steadily requiring more than 16-17 hours ventilation. And then we should orientate our algorithm according to weight. And clearly we have now a patient who could be also ventilated non-invasively with a home mechanical ventilator device if they weight as low as 2.5 kilos. So let's see how it is used in specific disease group and what are the peculiarities. In neuromuscular disorder, as we have seen, these are the main clients, the main population requiring home mechanical ventilation. And this is because they need support to treat hypoventilation or altered overnight, mainly overnight, altered gas exchange, because they need support to improve or to overcome the respiratory resistance supporting respiratory muscle function that are by definition weak, and because they need to offload the respiratory system and to have support and to have adequate tidal volumes. In ERS guidelines, there is a specific point about children with a neuromuscular condition, and as has been said, that NIV is associated with improvement in symptoms of sleep disorder breathing, as well as objectively improvement in nocturnal and daytime gas exchange. But what improves is also sleep quality and architecture, ultimately survival, but also is used to improve or to reduce the occurrence of chest deformity and with preservation of quality of life. Clearly, the benefit of NIV depends on the underlying condition and the progression and the prognosis of it. So there is another element I want to stress, because in neuromuscular disorder, particularly in spinal muscular atrophy, the disease-modifying therapies have widened the main scope of NIV. So now we prescribe NIV even in patients that have no strict rules for them in terms of alteration of gas exchange, but we prescribe them really early in the course of the disease to support them and to use it as a rehabilitation tool. In other words, to recruit alveoli, but also to reduce the rib cage stiffness. Because if we think these children will become adults, we need to think ahead and we need to allow them to reach their potential expansion of rib cage. And the current standard of care which have been issued before the availability of disease-modifying treatment may be outdated, and even the indication to NIV may be outdated. The change in disease phenotypes, what entails, they have an impact on the choice of mask and interface, and also on the ventilation settings. So we are observing now that the trigger required to, even for children with SMA type 1, we need to consider, for the first time in history of my experience, we need to swap the trigger to a less sensitive one to avoid over-triggering, but also the backup rate could be reduced because they're now able to trigger. And they would also need a higher window of TI because they are much more able to, again, to trigger, and their duration of their breath can be various. Also, the strategy has changed because, as I said, in timing of initiation has changed, and sometimes it's even more proactive than in the past. In the past, we knew that children, once they've been established, they would go on forever. Now we know that this is an investment on the future. Types of support has changed, as I have mentioned, and also the goals and the monitoring type and timing of monitoring has changed. And the requirement of NIV, of home mechanical ventilation, in terms of duration of support has been used to measure the efficacy of disease-modifying treatment in clinical trials. However, if we did a real-world experience retrospective data, we would need that there would not be such a significant difference in terms of the use of NIV, but this is because we're using it more than in the past, if you like, not because of support, but again, because of rehabilitation. Spinal muscular atrophy is, we know, an autosomal recessive neurodegenerative disease that affects motor neurons, and children lack a protein that is the SMN1, which is the main protein that is placed and is located in the motor neuron. But there is another protein that is SMN type 2, which is a little bit shorter, but still active when SMN type 1 is lacking. And spinal muscular atrophy, we all know, is characterized by progressive muscular atrophy and weakness. And we distinguish different types. Type 0 is the most severe forms. Type 1 are children who are by definition not able to be sitting independently. Type 2 are children that are able to sit independently but are not able to reach the ambulation. Type 3 patients are children who are able to reach and to attain the ambulation independently, but then depending on their severity might lose it over time. And the natural history of spinal muscular atrophy type 1 was so severe that if you look at the Kaplan-Meier graph, you would see that in the dotted line, this is the natural history without a greater support than palliative care, and the average duration of average survival was no longer than 24 months, 2 years, but you can see that the survival was ensured with a high level, even longer, with high level of support, meaning invasive ventilation 24 hours per day and gastrostomy. And in 2018, as I said, the international standard of care were issued. And for SMA type 1, they consider 3-monthly assessment and 6-monthly for SMA type 2 and 3. And usually what the experts suggested was to carry out regularly assessment of the chest shape and chest auscultation, but also to prevent acute exacerbation through prevention with vaccination, for example, but being proactive with cough assist and management of secretion, and also start non-invasive ventilation as soon as children started a severe paradoxical breathing or when they started having respiratory impairment. And for SMA type 2 and 3, they've also suggested threshold where the risk of REM-related hypoventilation or sleep disorder breathing were more frequent, which was below 60%, and below 40% was more likely to be happening non-REM or REM-related sleep disorder breathing, and this was the threshold where non-invasive ventilation was suggested. But we now have 3 approved therapies, and 2 of them, the antisense oligonucleotide nusinersen and the small molecules risdiplam, target the exon 7 of the SMN2 protein. So in other words, they allow the exon 7 to be incorporated in the mRNA transcription, transduction, and to allow the transcription of the SMN protein. The SMN2 protein, as I said, is a shorter one, but still functional. And the more copies we have, the better the phenotype is. And the third therapy is the gene therapy. So this is a nuclear, is it SMA1 gene incorporated, encapsulated in a viral envelope. So the viral envelope is used to penetrate within the neuromotor cell, but not only, also systemically, and to incorporate the DNA to be transcribed and transduced into the protein. And this is a child who I have chosen because she's been diagnosed. She has been diagnosed at 2 months of age. At roughly 1 month, 15 days, 1 month after the diagnosis, she was dosed with a gene therapy. And you can see her, she was really floppy, she couldn't hold her head, and she was completely hypotonic, and even after dosing. But the follow-up at 13 months, so later than expected, but still quite surprisingly for SMA type 1, she was able to sit independently. And at 48 months, so 4 years of age, she was also able to take 1 step independently. And this is absolutely wonderful if we consider natural history of the disease. However, firstly, those steps, those milestones were achieved quite late in life, still great, but late in life. And I want to also highlight that around 4 months of age, she still required NIV plus mechanical insufflation to support her, because the way is very long from dosing to reaching this kind of clinical stage. So we need to be supporting them. We can't really think that this is a change happening overnight. We need to support those children. And in infant with SMA type 1, when we set an NIV, we should consider specific aspects that were completely unthinkable of in the past. So we need to be considering these patients would not be lying flat all the time, but would be reaching the upright position. So we should be choosing interfaces that promote interaction with the surrounding. We should ensure adequate lung expansion for alveolar recruitment, but as I was saying before, we need to also ensure adequate stretch of rib cage to prevent stiffness and bell-shaped thorax, not just in the shorter term, but in the long term. We also think that those children were lying flat, so they never virtually developed scoliosis. So now we are seeing patients developing scoliosis because of the seated position. So we need to be considering NIV to support surgery. Home mechanical ventilation and the secretion management choices should be integrated in the pathway of the therapeutic choices, in the switch of therapies, in the changes that we are expecting from therapies that are not codified or described anywhere so far. For Duchenne muscular dystrophy is slightly different because this is still a genetic condition that affects male, but it is characterized by the progression of the disease over time, and we recognize different stages of the disease: the ambulatory stage, the late ambulatory stage, and those children tend to lose ambulation in early teens. They have also cardiac dysfunction and often even cognitive dysfunction. Cardiac and respiratory failure are their main causes of mortality. And the standard of care, even for Duchenne muscular dystrophy, have been issued still in 2018, was a very prolific year. And the indication are for NIV to be started where there are signs or symptoms of overnight hypoventilation, which usually occur in the late non-ambulatory stage and late teens in patients when they have sleep disorder breathing documented at a sleep study, and when the threshold of forced vital capacity is below 50%. In terms of target of therapies, there are plenty. So virtually each step from the mutation in the MD gene throughout the end-stage organ dysfunction are targets for therapies. The reality is that for some treatment have been approved, but they are mutation specific. Such an example is eteplirsen in US with skipping 51. So mutation specific therapies not available for all patients with Duchenne muscular dystrophy. So the only mutation-independent therapies that have been approved are corticosteroids. And we've studied how the corticosteroids impact on respiratory function in Duchenne. And if you look at the dotted line and the straight line, you can see that compared to the more fine dotted line that are naive children, those treated with different regime of steroids have still a similar decline, but starting from a higher FVC, and ultimately this leads to, if you look at the threshold for forced vital capacity, which is associated with a higher risk to requiring NAV, patients treated with steroids are significantly, roughly 2 years, requiring likely to require home mechanical ventilation or to reach the FVC below 50%. So in Duchenne muscular dystrophy is less striking than in SMA, but definitely the steroids plus the standard of care have improved quality of life and prolonged patient survival. So we are now thinking of those children or early teens as adults. So now the time of initiation is roughly 16 years of age, depending on the clinical picture and depending on the severity of sleep disorder breathing, but the type of support can be different. Again, the use of home mechanical ventilation has been used as measurement of treatment effectiveness, and it is not always easy to discriminate, because the use of home mechanical ventilation, the need for home mechanical ventilation really depends on so many different factors. But we should be thinking ahead, and we should be thinking of them becoming adults and requiring independent life. So, for example, mouthpiece ventilation should be considered more and more for those patients. When it comes to central congenital hypoventilation syndrome, this is a much rarer condition. However, it is typically characterized by, and this is the condition really where the ventilatory support is life support. There are patients who have central hypoventilation that is due to a reduced absent ventilation response to hypercapnia and hypoxia. So centrally, there's no drive to overcome or to correct the alteration in gas exchange. And there are also autonomic dysfunctions such as Hirschsprung disease and neural crest tumors. So again, in relatively recently, so last year, has been issued the standard of care for central congenital hypoventilation syndrome, and really always patients should be considered to require spontaneous and assisted ventilation at least, and children below 2 years of age should be assessed every 2 to 6 months. And interestingly, whereas after 2 years annually, and interestingly, those children should be tested overnight with a sleep study, but also during wake. This is because during wake and overnight there is a significant shift in the control of breathing, in the gas exchange, but also in the pattern of breathing. So they even might require different settings, daytime and overnight. And considering that the trigger, the ability to trigger and the ability to drive is what really drive the change. And those patients who cannot really manage with non-invasive ventilation should be considered to have tracheostomy. Trisomy 21, conversely, is quite common, if you like, and is the most common chromosomal disorder, and has different aspects again that predispose children to the development of mainly obstructive sleep apnea, and the prevalence is quite variable but quite high if we consider that 5% is the average OSA prevalence in otherwise healthy children. And this is because children with trisomy 21 have microglossia, but also midfacial and mandibular hypoplasia. So they have facial features that predispose them to have obstructive events, but they also have muscle hypotonia, particularly the upper airway are really floppy, and they have adenotonsillar hypertrophy, and sometimes associated with subglottic or tracheal stenosis. And the facial features and the upper airway hypotonia can change throughout life and reducing also the severity of OSA, but it needs to be checked regularly. So that's the American Academy of Sleep Medicine suggested to carry out an OSA screening with cardiorespiratory polygraphy by the age of 4 years in children with trisomy 21. In terms of ventilatory support, the first choice is always CPAP or NIV, depending on if the obstructive events are also associated with altered gas exchange, but also depending on the comfort of the patient. In a large cohort, almost 2% of children required tracheostomy at 7 months of age, but 9 of them, so almost half of them, were decannulated after 2.2 years. This is because the course of the disease tends to stabilize over time. Trisomy 21 is crucial to identify OSA and sleep disorder breathing because the treatment with NIV improved cognitive function, improved behavior, has a massive impact on behavior and reducing the daytime sleepiness by also improving the quality of sleep, and also reduce the cardiovascular complication. Clearly, we all know that for trisomy 21, the adherence is an issue. So we need to be very, very supporting them with a proper environment, with the use of play therapies, behavioral intervention. At the time of the establishment, choose the correct mask is crucial, and often NIV can be better tolerated than CPAP alone. We need to consider that, as I said, the establishment or establishing a child that is complex by definition to home mechanical ventilation really require a multidisciplinary approach and multidisciplinary effort. The experience at the Brompton was to an annual review pathway where a child coming for a sleep study overnight also received a multidisciplinary assessment on that day by chest physiotherapist, clinical nurse specialist, cardiologist, and medical review. And the case was discussed in ward round, and the full discharge letter was issued. Children on the first establishment should be also given an emergency plan for exacerbation for the DGH or the local hospital, in terms of well and unwell settings, or how to manage all the different level of support that are available in the home mechanical ventilation devices nowadays. But also the training and the formalized training of patients, parents, and caregivers are crucial at the time of discharge. So how we should be monitoring them at home? Full PSG was suggested as a first choice in the ASM guidelines in 2011. However, the latest ERS guideline suggested cardiorespiratory polygraphy is a more than enough, more than adequate surrogate, if you like, but also, if not possible at all, an overnight oximetry coupled with capnography can be carried out, but at least every 6 months. And we're now able to remotely manage patients on home mechanical ventilation, and we can use this remote management in terms of diagnosing sleep disorder breathing, because we can do home-based sleep studies. We can assist them in order to prevent exacerbation. There are several experiences now described in terms of teleassistance with video assistance to prevent exacerbation, but also we can remotely monitor the compliance. We can adjust their settings. We can offer troubleshooting remotely and preventing decompensation. So we really can work remotely on different plans and different years. There is an experience that has been published in 2021, and I have to say COVID has changed pretty much everything. And this was based on ventilator integrated polygraphy and capnography, and we have associated them. Well, we sent capnography separately, and we used remote monitor with a cloud hosting. So what we really assessed was the adherence of patient, the use of the ventilator, but also the leaks. So the adequate use and the adequacy of the interface, but also we were also able to change the setting remotely. Clearly, in accordance to parents and patients, wherever needed, remotely based on gas exchange. ERS suggested that we should be carrying a closer monitoring on patients at home if we want to keep it remote, and not ask patients to come over for a check after establishment, at least 1 month after initiation, but then it can be followed by every 3 to 6 months, either visits or remote monitoring. And this is quite similar to also Canadian Thoracic Society recommendation. the integrated softwares are definitely, as I said, an important role in monitoring, and they can give reliable information in children managed at home. And in the last model of ventilation, we not only have the information given from the ventilator in terms of flow, pressure, leaks, and so forth, but we also have polygraphy integrated. So we're able to really couple up the information given from the ventilator, but also information from the cardiorespiratory polygraphy of the patient, and really associate it and make changes according to the physiology of the children. ERS, when to consider weaning. So these are children that we need to think about it, just because, well, because some children naturally improve, considering their age and considering their underlying condition, but also in terms of those children who are supported or have been treated with disease-modifying treatment. So ERS suggests to consider weaning when gas exchange has improved. So when the definition of hypoxia and of hypoventilation are over or overcome or resolved, or when there are less than 10 events per hour at polysomnography in terms of OSI. They also suggest to wean those patients carefully, and then to leave a washout period, and then to assess them again, because those patients sometimes can be really, really tricky and can build up again sleep disorder, breathing, or alteration over time. So we need to give them really a washout period after the weaning to really consider them and to reassess them. Thank you very much. It's been a pleasure talking to you, and I'm very happy to take questions. Thank you.